medical student doing the MRes of Translational Medicine. 1 second. This year, also a representative for Neurosoc and also Nancy, regional representative for Liverpool as well. So I'm going to be talking us through a couple of different topics. It's sort of like neuro for finals. I've tried to keep it sort of reasonably succinct and not sort of bang on too much, because obviously it's a lot of stuff to go through and it's pretty early on in the year as well, so you've got a lot of time left still. So the stuff I'm going to be going through is stroke, headaches, some Chord syndromes, brain tumours, Hydrocephalus, Guillain-Barre syndrome, and Coma. So I was going to do a little poll here, but I don't think we've got the access to it, so I'll just sort of talk through it and try and sort of keep it moving forward. So this scan here on the left, as you can see, there's a little bit of whiteness that can be seen, sort of increased intensity, and that would be corresponding to a diagnosis of C, an acute extradural hematoma, and that can be seen because the bleed is lens shaped. So moving forward, this would be a chronic subdural, and the difference in this case between a chronic and acute subdural is that on the scan here you can see that the blood in the brain here has gone darker coloured as opposed to sort of bright and intense, and that's really how we can tell the difference between a chronic and an acute subdural. So I think normally they say it's 1 to 2 weeks, and I think 2 weeks is usually the cutoff that's given for the differentiation between an acute and a chronic subdural bleed. And so that's sort of what you're looking for on the imaging to sort of differentiate between the two. Again, I would have sort of done a poll here, but as you can see on the scan to the left, you can see a little bit of there's nothing sort of standing out, but you can almost see a little bit of a starfish shape in the middle. I'm not sure if you can see my cursor at all, but yeah, so that's actually blood in the subarachnoid space, and that is actually called the starfish sign as well, and that's sort of imaging indicative of a subarachnoid hemorrhage. So when you talk about subarachnoid hemorrhage, there's a couple of different sort of complications that can arise from this condition. The two main ones to know about, I think, for finals, obviously there's a couple of different ones, but the two main ones to know about are vasospasm and hyponatremia. Vasospasm is sort of prevented by giving patients this calcium channel blocker called nimodipine, not to be confused with nifedipine or amlodipine. Nimodipine is the one that's sort of, and it's, as far as I'm aware, it's really the only indication that I've seen this is used for, and they don't tend to use any of the other calcium channel blockers for this. And hyponatremia, again, another one that you might see in finals questions. As to sort of why this happens, I don't really know. I think there's some element of SIADH that occurs, but yeah, just to remember really for finals. The other stuff that can happen, rebleeding, I think occurs in about 10% of cases. A huge cause of death in these patients is rebleeding. Obviously seizures can happen. Hydrocephalus as well is another sort of complication in the long term for these patients. So stroke is quite an important one to know about for finals. I'm not sure if it's the same now, but for us, one of our CBLs that we had was actually pretty much solely to do with stroke, and it touched a lot on the different classifications of it. And this is what's on the screen here is the Oxford-Banford classification of strokes, and I've got a slide coming up that's got the full details of it. But it's split up into a total anterior circulation stroke, which requires 3 of homonymous hemianopia, unilateral hemiparesis or hemiplegia, and higher cortical dysfunction, which is usually some kind of dysphasia. And then you can have a partial anterior circulation stroke, which is only 2 of the above, and then you can have a lacuna infarct as well, or a lacuna stroke, which is sort of an isolated motor dysfunction, sensory dysfunction, or sort of other cortical dysfunction. So this is the full breakdown. As you can see, it's from Geeky Medics. So this is really good. It's quite important to remember these, because I think for finals especially, it's easy marks if you know it, and if you don't know it, then it's one of those things that you're just never going to be able to guess it. So yeah, I would say probably worth having a look over it. I'm not really going to go through everything now because I think in the interest of time, it's probably not worth it. So I've got another question here, which I can't ask anybody. So the scoring system that's used specifically in A&E to try and differentiate suspected stroke. So this would be the Rosier score. The FAST score is one that obviously everyone's pretty aware of, even the general public are quite aware of it, and I think it's got relatively good PPV, so positive predictive value. ABCD2 is a TIA scoring system. The NIHSS, I can't actually remember what I put that was. Rosier is the A&E department, obviously, and then the SBNS is the Society of British Neurosurgeons, so that's nothing to do with it. So important thing to know for headaches for finals. Features of cluster headaches is an important thing to know. Treatment for an acute cluster headache, so the acute treatment, and then some preventative treatments for cluster headache. And then it's also worth knowing a little bit about migraine as well, and the management. So the features of a cluster headache, so these are typically unilateral. They tend to last in sort of short clusters, 15 minutes to sort of 3 hours, and they tend to come once, and then patients will have a bit of a sort of a time span where they don't have any attacks, and then again they'll get a sort of, as the name suggests, a cluster of events. The pain in these is typically felt retroorbitally, so sort of behind the eyeball, and they can also get symptoms such as lacrimation, red eyes, and excessive tearing, which is due to sort of autonomic disturbance. The patient that sort of typically is seen in sort of a question stem would be like a young bloke who's got up at night and got this sudden sort of painful headache, doesn't want to sort of sit still, and that's sort of quite juxtaposed to migraines, where the patient also wants to curl up in a dark room, have this sort of like intense unilateral headache, but they typically have the sort of the photophobia and the phonophobia that's associated with that. In addition, sort of autonomic symptoms that the patients can get are ptosis and meiosis as well, and that can resemble a Horner syndrome. And this can be triggered by alcohol as well and made worse by alcohol. So for the acute attack of a cluster headache, I'm sure most of you will know it's sort of high flow, 100% oxygen through a face mask, and this is typically pretty good at sort of helping with these attacks. You can also give patients subcutaneous sumatriptan, and then prevention, verapamil and lithium. I just forgot to put a slide in as well, but just to mention as well, for migraines, the acute management for migraines is typically they would give like an NSAID, a paracetamol, and maybe even a triptan for the acute phase. And then for preventative stuff, it would typically be topiramate or propranolol, so a beta blocker. I think it's quite sort of like typical of past med questions to sort of say for the preventative stuff, what would you give, and then give some contraindications for these. So obviously for a beta blocker, propranolol, you wouldn't want to give that to an asthmatic patient who's also got migraines, and then also topiramate as well as teratogenic. So just to be careful in either pregnant women or women of childbearing age. So status epilepticus, obviously epilepsy is important to know for finals, but kind of beyond the breadth of this talk. So for your initial management, if it sort of varies depending on the situation that you're in. If you're in the community and there's no IV access, your only real options, to be honest, are to give either buccal midazolam or rectal diazepam. And then really at this point, you just need to be sort of escalating and trying to get the patient admitted to hospital if the seizure is not terminated. If the patient's in hospital and you've got IV access, then you can move on to the next step, which would be to check their glucose. And the dose that you would give IV for a benzo in this situation is different. You would typically give IV lorazepam, and that's 4 milligrams. So the way to remember the doses for these, and I think it's probably worth knowing because it's pretty easy to remember, the buccal and rectal doses are both 10 milligrams, and then the IV lorazepam is 4 milligrams. After the IV lorazepam, you can move on to some phenytoin, and also want to sort of prompt for some anaesthetic input as well at this point, and consider sort of the more heavy duty stuff like phenobarbital, and consider the patient for ITU and sedation. Also, just note as well that I think the definition of status epilepticus has changed over the past couple of years. I think it used to be like 30 minutes, maybe less, maybe 15 actually, 30 to 15 minutes for the diagnosis to be made. Obviously, people would start treating before then anyway, but now the sort of time frame that you have to be in status 4 has changed because it sort of reflects the severity of the condition. So now it's only 5 minutes, or if the patient is having multiple seizures with no recovery of consciousness between the episodes. Sorry, a second. So just put a tiny little bit on Chord syndrome. So this is kind of a bit of a miscellaneous thing. Again, I think the one sentence summaries are probably enough for this for the purposes of finals. So Brown-Séquard syndrome, I'm sure most people will have heard of because it's quite, in practice it's very rare, but it's quite sort of a characteristic one and easy to remember. So patients get a weak leg and a numb leg. So that's typically they'll have weakness, loss of vibration and proprioception in one side, and then on the other side they'll have sort of a contralateral temperature and pain loss, and that's just due to the hemisection of the cord, as you can see on the diagram at the bottom. Patients can get a central cord syndrome, which typically occurs due to hyperextension injury of the neck. This can present with like a weakness of the arms, and typically they get like preserved motor and sensory supply to the legs. Anterior cord syndrome, and that's due to a flexion injury as opposed to a hyperextension injury, and that presents with loss of spinothalamic and corticospinal tracts. And there's a greater loss of power in the legs than there is in the arms in these patients. So these, I would say, these are probably worth just sort of learning this so that you can pick it out of the STEM for the finals questions that you might get. Syringomyelia, so that's where you get like a dilated syrinx, so dilated, it's almost like a cyst within the spinal cord, and these patients present with CAPE distribution, so they get loss of pain and temperature, but preserve proprioception and vibration, and that's sort of in sort of the shoulder region, and sort of, you know, as they were wearing a cape, basically. Move forward. So next, Guillain-Barre syndrome. So I'm sure this is one, again, that most people will have heard of. The sort of textbook definition of this is an ascending demyelinating neuropathy. In reality, so they sort of, in the textbook, it'll say this patient sort of lost the ability to walk, and then they lose their hands, the ability to move their hands. In practice, patients that I've seen with this, it tends to be a bit more variable. Sometimes they lose it in their legs and then it goes to their arms, or the other way around. And there's a couple of different subsets of this condition as well, like Miller-Fisher as well, but that's probably a little bit beyond finals. So this occurs due to an autoimmune response to a pathogen. Typically, I think most commonly it's Campylobacter, and so the patient might have a history of a GI infection in the weeks prior to this weakness onset. And that's due to an element of molecular mimicry between antigens that the pathogen can have being recognised, and your body then attacking myelin within the nerves. The symptoms these patients present with are weakness, which is, as I said, ascending, altered sensation, and then on examination they can get reduced reflexes, which can be sort of either reduced or absent. The major complication in these patients, and something to be aware of, is that they typically, if it progresses far enough, can get sort of respiratory depression. And if you ever see these patients on the ward with Guillain-Barre, you can get sort of extra points by pointing out, if the consultant asks you to say, if they say, oh, why is there a peak flow by the side of the bed of this patient? Or you can say it's because every couple of hours the nurses will come and ask them to do it and monitor their respiratory effort. So if that's dropping off, you know that they're deteriorating and they might need some respiratory support. So the diagnosis for GBS is predominantly clinical, but on a lumbar puncture with CSF, they can get an isolated raised protein. Patients with GBS can also get hyponatremia as well, and I think that's due to a similar sort of SIADH type thing as with subarachnoid hemorrhage. The management of these patients, it's predominantly conservative, but if they get and plasmapheresis or plasma exchange, the mortality rate can be as high as 5%. So I won't really sort of bother going through this because it's just kind of one of those things that you have to learn, and I'm sure most people will be aware of this at this point. But the difference between upper motor neuron and lower motor neuron lesions. So in upper motor neuron, obviously you get no muscle wasting clonus, hypertonia, brisk and sort of normal reflexes, spasticity, and then in lower motor neurons, lesions, you can get muscle wasting, fasciculations, hypertonia, and diminished or absent reflexes. Obviously, a condition where you might get a mix of these two would be ALS. And in ALS, typically, I think nerve conduction studies are normal, but you would obviously there's a predominantly clinical diagnosis, and you can also do an EMG to help assist with the diagnosis. So Horner's syndrome, it's a bit of a medical school and post-med classic. Patients present with the sort of triad of ptosis, meiosis, and anhidrosis, or enophthalmos, which is retraction of the eye into the eye socket. It's due to a lesion affecting the sympathetic nerve system, which is sort of traveling down into the neck and then up back to the eye. The most common cause is a Pancoast tumor, which is like an apical lung tumor. And the diagnosis again is clinical, and really the management is to treat the underlying cause, which in most cases will be due to a tumor. Hydrocephalus, quite simply put, is an enlargement of the ventricles. Classically, it's sort of broken down into two different types. You can either have obstructive or communicating. So the obstructive causes are typically tumors, brain bleeds, or cysts. And then the communicating causes subarachnoid hemorrhage and meningitis, and those are the main ones to know. But you can also get rarer stuff as well, like choroid plexus papillomas as well. But that's sort of, yeah, quite rare. And the childhood signs that you might see with hydrocephalus are sort of like patients can get like quite big heads, dilated scalp veins, bulging fontanelles, and they can get this thing called sunsetting as well, which is where the eyes sort of stick down at the bottom and they struggle with sort of vertical gaze. And the treatment of this condition is with a VP shunt, or just shunting basically. So they insert a shunt into the ventricles through the head, and then either stick it to the peritoneal or just shunt it. This is how the patients can sort of look with hydrocephalus. So as we said, they've got the large head, bulging fontanelles, dilated veins, and the sunsetting of the eyes as well that can be seen there. And as you see on this diagram here, that's the pressure before and the pressure after a shunt has been inserted. So just quickly, obviously this could be a talk in of itself, but infections in the CNS typically split up for the purpose of finals into meningitis and encephalitis. So meningitis is a triad of headache, stiff neck, and fever, and that's investigated with a lumbar puncture. And there's a whole table. It's worth just sort of, I'm not going to go through that now just in the interest of time, but it's worth just sort of looking at that and working out a way to remember which ones is which. The treatment for viral meningitis is conservative, so you don't need to do anything for them. And if it's bacterial, you want to give them some broad spectrum antibiotics and some steroids as well, and that's to help reduce the risk of sensorineural hearing loss and other complications because of this condition. Patients also need some neuro rehab as well, usually. I tend to remember encephalitis as think of it as almost like meningitis plus. So they can get as above with meningitis, but then in addition, they can also get like affected GCS and mental status, confusion, headaches, and seizures as well. Seizures is the big one, and to help differentiate. On investigations again, so you would do a lumbar puncture, you see a pleocytosis in viral, and in autoimmune causes, you'd see antibodies. And then you can also consider other stuff like MRIs and EEGs. The treatment for encephalitis, so it's autoimmune, you would do some immunotherapy. If it's viral, you can do acyclovir, and that's typically a sort of HSV. So herpes simplex encephalitis is quite sort of the common cause, and that can be with or without antiepileptics. I think there's quite a lot of research going on into that at the moment, whether that should be given. And then again, neurorehabilitation for these patients is important. So not far off the end now, only a couple of slides left. So CNS tumors, so I've touched on this a bit. I think it's not worth knowing a massive amount about this because I don't think you'd get asked a lot about different tumors that can present. But again, just an awareness of them is sort of going to be beneficial. So CNS tumours are not graded in the same way that many other tumours are graded. Instead, they use the WHO grading classification, which is a histological sort of criteria as opposed to the TNM staging system. The common types to be aware of split up into malignant and benign. So the most sort of common malignant one is a glioblastoma multiforme, or a GBM, and that's more common in adults. And then in peds, they get medulloblastomas. And then benign lesions, so meningiomas, most common cause, the most sort of common primary brain tumor, more common in adults and are quite often incidental. And then pituitary adenomas as well, which are more common in adults, as are vestibular schwannomas. Just to sort of note at the bottom there, though, that most intracranial tumours are actually extracranial mets, and the three most common of those are bronchus, breast, and bowel, and obviously bronchus being lung cancer, so lung cancer, breast cancer, and bowel cancer are the three most common causes. So the presentation of these tumours can be quite variable. So the high-grade ones that are quick growing can present with headaches and nausea, and that's due to the raised ICP, or raised intracranial pressure. And the low-grade or indolent growing ones are typically more of a progressive neurological deficit. And these patients, regardless, can present with generalized or focal seizures, which is common in both sort of quick growing and slow growing tumours. The location of the tumour really relates to the presenting symptoms, and that's sort of pretty obvious in terms of the area that's being compressed or the area that's being eroded by the tumour is going to be relating to the functional anatomy of that sort of region of the brain. And the diagnosis of these tumours is with MRI and neuroimaging. The management of these, I think, obviously, it's not really worth knowing a vast amount about the management and the diagnosis of these, because I think it's probably a little bit beyond what you'd be expected to know for finals. But really just surgery, radiosurgery, and chemotherapy like temolazide is what's used for these patients. A little bit about acoustic neuroma specifically, because it seems to be a bit of a favourite of past med and medical school exams. So it's a benign tumour of the cranial nerve, of the eighth cranial nerve or vestibulocochlear nerve. If it's bilateral, then consider if the patient has neurofibromatosis. Obviously, in real life, it's rare, but I mean, for exam purposes, if they've got bilateral acoustic neuromas, then just consider it. Acoustic neuroma is more common in women, and it accounts for pretty much all tumours that occur at the cerebellopontine angle. These patients present with sensorineural hearing loss, tinnitus, and vertigo, although vertigo can be an uncommon symptom if the tumour is not rapidly growing, because the vestibular system has time to adapt and sort of compensate for it. And the diagnosis is with MRI. And again, surgery is the treatment of choice for these patients. I've just put a little picture of Mark Ruffalo on there because it's a little known fact that he actually is deaf in one ear from an acoustic neuroma. So Bell's palsy, it's a lower motor neuron lesion of the facial nerve. The risk factors related to developing a Bell's are upper respiratory tract infection, pregnancy, diabetes, hypertension, and immunosuppression. The symptoms are facial paralysis that's usually pretty subacute, so within hours is the onset, and patients can also get hyperacusis as well, which is sort of increased volume of hearing, and that's because the stapedius muscle, which is sort of within the ear, is innervated by the facial nerve. Bell's palsy can be differentiated from a stroke, and that's typically done, I'm sure most people know, because if it's a upper motor neuron lesion, as with a stroke, you get forehead sparing, which you don't get with Bell's palsy, and I've got a little diagram in a second that sort of illustrates that quite well. The treatment of Bell's palsy is with steroids, and you get a better response if you start those within 72 hours of the symptom onset. And steroids are important, but the most important thing with these patients is to actually consider eye care and making sure that at night the eyelids tape down, they've got drops for the eye, because obviously if the eye gets damaged while the patient can't control it, then that's going to be something that could actually end up being worse than the Bell's palsy in and of itself. And the complications of Bell's palsy, they can get this thing called aberrant reinnervation, and they can get crocodile tears. So basically crocodile tears and synekinesis. And these are when patients will get, so when they salivate, they'll get sort of lacrimation, tears forming, and synechisis is when they can sort of smile, and that will cause their eye to blink as well. So it's just due to sort of misconnections on the sort of reinnervation of the nerves. And this is a nice diagram that demonstrates it, the difference between how a stroke and a Bell's palsy would present. So as you can see, you've got a bit of a crossover in terms of the nervous supply to the forehead, which you don't have if the lesion is below the nucleus. Finally, just to talk a little bit about coma. Again, I think this is probably one of those things that's not really worth me sitting and sort of going through, because it's kind of just, you kind of just have to learn it, to be honest. But there's quite a good mnemonic for this. If you remember MOVE, or MOVE 654, and that stands for motor, which is 6 points, voice, which is 5 points, and eyes, which is 4 points. And as you can see on the little diagram to the right here, that sort of corresponds to each level. And if you know that, so one of the ways that obviously if you're trying to learn a lot of stuff for finals, one of the ways that you can sort of get around having to learn this off by heart is if you know that 3 is the lowest possible score that you can get for GCS, so 1 for each. And then if you know MOVE 654, you can kind of work out what's in between if you've got a rough idea of what each of them should be. And then finally, just sort of when considering patients who are in a coma, obviously you need to sort of go through systematically and use your sort of surgical sieve, so your vitamin A's or whatever it is that you use for surgical sieve, to think about the different etiology that could possibly be causing this. So this is the end of the talk. I think John is going to take over in a second. I hope it was useful for everybody. My email's on the slide there, so if you have any questions about anything or you want to get in contact for any reason, just drop me a message. And I hope you'll all complete the feedback and give me good feedback. Thank you.
Okay, so following on from what George has just done, I'm going to cover some slightly different topics. So in a similar vein, I'll try and keep it to sort of the useful exam stuff. Apologies if I look like I'm kind of away in the distance. I've got a monitor that's slightly above the webcam. But so what I'm thinking is I'm going to cover Parkinson's disease and MS in slightly more detail, because they're kind of core cases, which will be really helpful for OSCEs and things, to kind of have your kind of knowledge about. And then sort of some of the key neurology. I won't sort of linger on stuff like low motor neuron versus motor neuron. And in the interest of time, sort of I'll do HD and dementia, and try and just do the key points really. That'll be helpful. Obviously we've got a limited time, but if anybody has any questions now or throughout or at the end, then please feel free to ask and I'll try and help. Okay, so we'll get straight into it. So Parkinson's disease, one of the most common neurological conditions, as I'm sure you're all aware. Typical age is 60 to 70 years, so that's quite useful if you've got an MCQ. It will tend to be that sort of age range. And it's a chronic neurodegenerative movement disorder. And what you want to remember is this phrase, depletion of the dopaminergic neurons in the substantia nigra. That's the classic exam phrase. And so the reason it causes what it does is because it affects the basal ganglia and movement. And that leads to the classic symptoms, which I'm sure you're all aware of, which is tremor, rigidity, bradykinesia, as well as sort of postural instability as well. That's kind of like a fourth big feature. But obviously you've got these other symptoms that are quite common in Parkinson's disease as well, that sometimes actually come on quite early as well. So anosmia, so loss of smell. Depression's really prominent in Parkinson's disease, and autonomic disturbance becomes a problem further along the line, really. They're known to have quite poor sleep generally, and memory and cognitive impairment eventually sort of kicks in later down the sort of disease pathway. So I'm going to sort of cover some stuff on the clinical signs, just because it's quite useful to know and to kind of understand. So if you've got the patient in front of you, you want to check their gait. Have they got difficulty initiating movements? Maybe it's getting out of the chair. And are they shuffling with their footsteps? Are they freezing in doorways? They might have difficulty turning when you want them to come back towards you. And often they have reduced arm swings, so they tend to keep their sort of shoulders up like that. And then when you're having another look, They've got a resting tremor, often described as pill rolling. I don't know if you can see my camera, but like that. And it's 4 to 6 hertz, which just means 4 to 6 times per second. And they have this mask-like face, which is quite prominent in Parkinson's disease, where the emotions doesn't seem to sort of carry through. And that's often associated with low mood, actually. And then they've got this rigidity, which I'm sure you're aware of, cogwheeling, which is just that term that means rigidity with the tremor superimposed on top of it. And often the power and reflexes are normal. Micrographia is a sort of a useful phrase to remember, and that's just when the writing gets smaller, they'll often complain of that. And coordination is often normal. So it's important when considering Parkinson's disease that idiopathic Parkinson's disease isn't the only thing that causes Parkinsonism, which is these sort of symptoms. Drug-induced Parkinsonism is a very common sort of second cause. And there's also these things called the Parkinsons Plus syndromes, multiple systems atrophy, progressive supranuclear palsy, which I'll cover a little bit later, that they're kind of not very common in practice, but they're useful to be aware of for exams. And it's the same with Lewy body dementia is a bit more common, but I'll cover that kind of nearer the end with the dementia stuff. So drug-induced Parkinsonism is the second most common cause of Parkinsonism after idiopathic Parkinson's disease. And when you're thinking about what drugs might cause it, just think what affects dopamine. So it's a lot of the psychiatric drugs. So things like chlorpromazine and haloperidol, which are the kind of older typical antipsychotics used often in schizophrenia, or the atypical antipsychotics, which are newer but still have this as a possible side effect, like risperidone, olanzapine, aripiprazole. You don't have to obviously know all of these, but it's worth kind of being able to recognize these sort of names. And antiemetics can also cause this. And metoclopramide is a really useful one to remember for exams. It can cause this thing called oculogyric crisis if you give it in young women. And that's why if you've got, say, an MCQ stem of a young woman of childbearing age who needs an antiemetic, don't give metoclopramide. That's what they'll be trying to push you away from. And just as a side note, domperidone is another antiemetic that acts in a similar way on dopamine sort of pathway, but it doesn't cross the blood-brain barrier as much as metoclopramide. And also you can get these features like acute dystonia, akathisia, which is just that kind of slowing and almost stopping of movement, and tardive dyskinesia, which you might have seen pictures of, where people kind of have this kind of writhing of the neck, and often they can't control their mouth and their tongue. So I'll just do a little bit about the Parkinson's Plus syndrome. So multiple systems atrophy, the kind of the bold throughout this talk, those are the key sort of take-home points that you'll be able to see on the slides when they get sent out later. But for this, really, autonomic symptoms and early falls are the key features of MSA, that if the stem presented with that, then actually that would possibly be more likely than Parkinson's disease. And then there's this thing, progressive supranuclear palsy, and that's a vertical gaze palsy, so they won't be able to look up when you're doing your cranial nerve examination, and often they have early falls as well. And then dementia with Lewy bodies, as I've said there, I'll cover later. So in terms of making this diagnosis, it's a clinical diagnosis based on history and clinical signs, and NICE recommends sort of an urgent referral, untreated, so you wouldn't begin treatment if you suspected it in primary care. You'd have to go to a movement disorder specialist. That's somewhere like the Walton. And if they're on a drug known to induce Parkinsonism, like we've talked about, then you would want to stop it if you can, or refer to the specialist as well. And there's this thing called a DAT scan, which is basically just a dopamine transporter scan, which can show kind of where dopamine is being used up in the brain, and this will be reduced in idiopathic Parkinson's disease. So in terms of the management, if you had somebody like this, a Parkinson's disease case in an OSCE, it's really good to remember MDT approach. You want a neurologist involved, SALT, because often these people have difficulty with their speech and with their swallowing, especially later down the line. Physiotherapy and OT input, dietetics, again, with the swallowing, it might alter the diet, community nursing, neurology, for those more sort of autonomic problems that might occur later on. And mental health services is really important. And if you can say something like patient education and Parkinson's UK as an example, that would be really good in like an OSCE. It shows that you've kind of thought about it in a holistic way, which is always good. And just in real life, obviously, in general. So in terms of the drugs, so it's useful to know about the drugs for exams and beyond. Levodopa is the first line medication. It's usually given with a dopa decarboxylase inhibitor, which prevents basically the levodopa being broken down in the body before it reaches the brain, such as co-carel-dopa, which is called Sinemet as a brand, or co-benel-dopa for Madopar. I've not really seen much about that one. And when you see it written down, it'll have these two numbers, 100 milligram over 25 milligram, for example, where the 100 milligram is the levodopa and the 25 milligram is the dopa decarboxylase inhibitor. And as we've said there, it just stops the peripheral conversion. So you want to offer the levodopa early on if the motor symptoms are really affecting the life, but often you would consider perhaps not if it wasn't so badly affecting sort of daily life, because it becomes less effective the longer it's used. Okay. And there's some other drugs to just be aware of, useful to be able to recognize. So monoamine oxidase B inhibitors like selegiline, razagiline, just you don't really need to know much about them, just that they exist. Dopamine agonists, pramipexole, ropinirole. Now that's a drug you might perhaps recognize from, it's sometimes used in motor neuron disease. But obviously dopamine agonists, they have these issues of can cause sleepiness, hallucinations, which is one that I'm sure you're probably aware of, and these impulse control disorders. So I think everybody sort of tells that story about somebody who starts taking one of these drugs and then goes and gambles away their life savings, that sort of thing. So that's a good way to remember it. And these ergo, I think that's how it's pronounced, derived dopamine agonists, such as cabergoline, pergolide. I don't think they're used very often now, but it's worth being aware of them because they cause cardiac fibrosis. And that's something that they could ask in an MCQ, perhaps. Other medical options, I'm not going to cover in much detail. The slides will be going out, so you'll be able to have a little look at this, but in the interest of time, I might just skip over it. And obviously, it's a slowly progressive disease. If you have it in older age or you've had it for a longer period of time, it's worse prognosis. And importantly, dementia is much more common. So that's Parkinson's disease. I thought it'd be quite useful to just have a little bit of a think about benign essential tremor and compare it to Parkinson's, because this is something that is quite common. But benign essential tremor will be on both sides, and it tends to be slightly faster. It improves with rest and alcohol. That's one of the classic things they might put in a question, but it worsens with intentional movement. And that's sort of in contrast to Parkinson's disease, as it says below. So we'll go from there onto multiple sclerosis. So that, again, this is a relatively common neurological condition. It's often in younger people, classically sort of females more than males. And it's got these sort of risk factors like genetics, smoking, vitamin D deficiency, and this sort of thing where people in a more northern latitude tend to get it. So it'd be more common in somewhere like Sweden than Brazil, for example. And diet and obesity are thought to affect it too. So again, what's involved, useful to remember, an acquired chronic immune mediated inflammatory demyelinating disorder of the CNS. And it's characterized by having 2 or more white matter lesions separated in time and space. So that kind of concept of time and space is quite important in MS as a concept, really, because you can't really do it with just one episode with no other evidence of anything else. And it can have, obviously, as I'm sure you're aware, lots of different ways of presenting. So optic neuritis is quite a common one, double vision due to ophthalmoplegia, limb weakness, gait ataxia, etc. And so optic neuritis is a partial or total visual loss developing over hours to days. And this usually is associated with eye pain that's exacerbated by movement, and they may have reduced colour vision preferentially. An essential scotoma is this kind of loss and blurring of the central vision. People complain that they might be able to see an outline of something, but they can't focus in on the detail. And on a fundoscopy, you might see a pale swollen optic disc, and this thing called a relative afferent pupillary defect, which is basically when you've got a light and you've got a patient in front of you, you shift the light from the unaffected to the affected eye, and it dilates rather than constricts acting like it should if light is shining on it. And that's because it's kind of responding to the fact that the unaffected eye is no longer receiving that light. And it's to do with there's a sort of complicated link between the nuclei, which you don't really know anything about for finals. Transverse myelitis is another common way that MS might be presented. So you've got this focal inflammation in the spinal cord causing weakness or sensory symptoms below the level of the lesion. And you might have heard of a Lomitter's phenomena, which is this electric shock-like sensation that goes down the spine, and it comes on with neck flexion. I think that's a past medicine one that comes up sometimes. And it's very common in MS to have urinary symptoms, so your kind of classic frequency, urgency, retention. And signs in transverse myelitis tend to be unilateral, as it's usually only partial. So you'd obviously only have it on one side, and the muscle tone is usually initially reduced despite it being an upper motor neuron lesion. And that's to do with kind of how the spine deals with kind of initial insults and things. But you don't need to know much about that. So you might also have cerebral is useful revision of classic kind of features of cerebral lesions. So the ataxic gait, vertigo, clumsiness, dysmetria, which is this not being able to sort of do the finger to nose pointing test and heel to toe walking, which you might find on exam. And then brainstem syndrome, so things that affect the brainstem cause problems like ataxia, problems with eye movement, like double vision, this thing called oscillopsia, which is the patient will feel like their eyes are moving. They might have, again, nystagmus, and this internuclear ophthalmoplegia. So that basically is the thing that causes relative afferent pupillary defect sometimes. And then you've got sort of bulbar muscle problems, but we'll come on to that a little bit later. So this is quite a busy slide, and I apologize for that, but basically it's because MS symptoms aren't specific, and there's a wide differential as to why somebody might come in with the sort of symptoms an MS patient would have. So I've purposely written metabolic disorders in kind of a bigger font, because that's the stuff that's useful to know for finals particularly. So vitamin B12 deficiency, as you might know, causes dorsal column problems and problems with cognition. Diabetic peripheral neuropathy might cause these kind of isolated sensory symptoms and things. Hypocalcemia and hypothyroidism, you can also easily rule out with blood tests, as the same for copper and zinc issues. This other stuff's worth having an awareness of, perhaps, but it's basically kind of going through your surgical sieve and having a think, but you can have a look on the slide later. So as I've said, in terms of, just as a side note, OSCE and things, it's useful to kind of have that structure. I'm sure you started sort of developing where it's going from simple to complicated kind of tests and things. So always starting with bedside and bloods, and then going on to your imaging and more invasive tests and things. So bloods here, as are on the screen, I won't read it off to you. And then you've got sort of MRI head and spinal cord is a really useful investigation in MS. And you'd look for these inflammatory plaques. I'm sorry I haven't put a picture on, but you'll be able to find them quite easy on Google. They tend to just have these kind of discolorations kind of visible on the MRI that are the sort of inflammatory plaques of demyelination. And then a lumbar puncture, it's worth knowing that the sign that you might find is oligoclonal bands. That's quite a common sort of exam question. And then I've just put a note in about the McDonald criteria. I don't think we ever got examined on it, but this is the MS kind of criteria that's used. Okay, patterns of disease. This is important to know about. NICE says there's 3 main patterns. I think at med school we get taught that there's 4, and there are 4. But progressive relapsing is a rarer form, so you don't need to know as much about it. But relapsing remitting is the most common. It's about 85% of cases. And it's these sort of episodes of exacerbation of symptoms followed by periods of recovery and stability. And then secondary progressive is where somebody with this might gradually start accumulating all that disability and not having proper kind of remissions. And often they progress onto this, indeed 2/3 do. And then primary progressive is not kind of punctuated with these relapses. It's just a kind of gradually worsening sort of disease progression, which is a little bit sort of less common in 10 to 15% of cases. So I've just written about relapse definition, but it kind of is self-explanatory. You can have a look at that. Again, MDT management. So it's always a useful phrase to have in your kind of armory. So it's a neurologist, and specialist MS nurse is a really important one, because that's often the first sort of protocol that the patient will have. And health promotion is important, especially if you're thinking Minovsky. Always go in with that sort of very early on. Stop smoking, regular exercise, managing of other conditions. And if you can kind of remember to always throw that in for whatever patient you get, really, there's a lot of stuff that you can use for many cases. Physiotherapy are often involved, and OT as well. Just see how we're doing for time. Okay. So MS is often treated with methylprednisolone, 0.5 grams. You don't really need to remember the dose, but that is useful to know. Methylprednisolone, 5 days. And then there's these other drugs that are sometimes used: dimethyl fumarate, natalizumab, alemtuzumab, which are those biologic drugs. Worth being aware of those. And then I've written some other bits and pieces that actually it's worth being aware of, but I'll let you have a look at a bit later, just in the interest of time. So I'll just quickly cover bulbar and versus pseudobulbar palsy. So bulbar palsy is a low motor neuron lesion of the bulbar, or cranial nerves 9, 10, and 12, which cause dysphagia and dysarthria. And on examination, it's worth remembering it's just like thinking low motor neuron versus upper motor neuron. You get this fasciculating, wasted tongue, reduced palatal movement, you get an absent jaw jerk, and you get a raspy or nasal speech. And I've written about emotion because actually pseudobulbar palsy is sometimes associated with a sort of change in emotion. And causes for this are motor neuron disease, Guillain-Barre syndrome, syringobulbia, which is a bit like syringomyelia, but it's a bit higher up, and cerebral cancers, brainstem stroke, etc. A pseudobulbar palsy is an upper motor neuron lesion, and it's on both sides to cause the effect of the corticobulbar tract. So that's a bit like the corticospinal tract, but of the head. And you also get dysarthria and dysphagia, but the examination findings will show an increased gag reflex, a small spastic tongue, so it's small, sits at the bottom of the mouth, and they have absent movement of the palate, increased jaw jerk, and this high-pitched Donald Duck voice. I've not seen it in practice, but that's what apparently it is. And then labile emotions. Stroke is the most common cause. MS, MND, and head injury are also other causes. So a quick bit on Huntington's disease. You don't need to know too much about this for the exam, but the stuff that is worth knowing comes up quite a lot. So it's an autosomal dominant condition, which is caused by trinucleotide CAG repeats affecting the Huntington protein. It often sort of starts around 30 to 50, but sometimes it can occur younger in juvenile Huntington's disease. And it shows this concept anticipation, which is where the disease becomes increasingly severe and earlier onset in subsequent generations. And the classic features worth remembering is chorea, which is those sort of dance-like movements that are uncontrollable and get worse through the disease course. They get psychiatric and cognitive features, and they have quite a high suicide risk because of the kind of nature of the condition and how quickly it can progress. And family members are often affected as well. A lot of people who get affected with Huntington's disease do try and hide it from others because they're either ashamed or worried about what will happen going forward. So it's worth bearing in mind. And it's a diagnosis that will be made by a movement disorder specialist involving genetic testing, and pre and post test counselling is important. I don't think I've got much more on that yet. And just, yeah, we don't know how to actually treat it to cure it, but we can slow the progression using sort of this MDT approach again. And then symptomatic medical treatments, as you can see there. Unfortunately, life expectancy is quite poor still, only 15 to 20 years following symptom onset, and they tend to drop off relatively quickly sometimes as well. But so that's worth just being aware of. And lastly, I'm sure you'll be glad to hear, is dementia. And this is a big topic, so I have tried to keep it to the key points. But if you have any questions, I'm sure the sort of paramedics team will be able to pass you my email if you want. So dementia is a progressive global decline in cognitive function without impairment of consciousness. That bit's important because delirium, which is something that it often gets confused with, and and is more acute, tends to have impairment of consciousness. And often somebody who has dementia will be more at risk of having delirium, so it can get very messy. So as I say, I'll try and cover the key stuff. So it's the most common dementia, Alzheimer's. Always good to say what you're talking about. And it's associated with these sort of pathologically, these neurofibrillary tangles and beta amyloid plaques, which I'm sure you've heard of, but it's useful to have in your brain, in the frontal and temporal lobes. The genetics, I don't think you really need to know, but just in case you might recognize it in the future, it's this presenilin-1, presenilin-2 genes and ApoE4 is involved in the later onset type. Down syndrome increases risk. That's worth remembering. I think we've had sort of sessions on that when we were getting taught about Down syndrome. And most of them are sporadic. There's other risk factors here that's worth considering, like atherosclerosis, family history, hypothyroidism, depression, etc. And you want to be looking into these when you're working up a patient who you think might have Alzheimer's. So they have a poor short-term memory, which is often the earliest symptom, and that will bring them into your clinic. And as their disease advances, they sort of lose these skills like verbal skills, abstract thinking, judgment, and complex task performance. And this has a real impact on ADLs, and it's often actually that it's friends and relatives that notice these deficiencies before the patient does. Often the patient doesn't have very good insight into their function. They tend to have poor sleep, low mood, they're sometimes disinhibited, and self-neglect is also a feature. Always get a collateral history. If that ever comes up in an OSCE, it's a patient who has Alzheimer's disease, always remember for dementias, a collateral history is super important. And if somebody presents with a new confusion, then you want to be thinking of acute illness, because that's the reversible stuff that you need to rule out before you can diagnose something that's progressive and irreversible like Alzheimer's. MRI is often done. So if you've ever been to sort of a memory clinic on your placements, you'll see that often if somebody's come in with this new kind of confusion and sort of reduced function, they'll have an MRI just to make sure there's not some sort of subdural hematoma or cancer sort of lingering. But it is a clinical diagnosis when it comes down to it. Once everything else has been excluded, you can use an MMSE, which is that mini mental state examination, or a MOCA, which is the Montreal Cognitive Assessment, and they're just sort of versions of often paper-based cognitive examination that you might have seen. So drugs for Alzheimer's is worth knowing for exams. So there's two main types really. There's your anticholinesterase drugs, such as donepezil, galantamine, rivastigmine. And the way they work is they increase cholinergic transmission in the brain. And if you remember that cholinergic transmission in the brain is kind of like wakefulness and this sort of thing, and it helps learning. And that's one of the features of these drugs. It improves new learning, at least for a time. But it's got these sort of rather unpleasant side effects of anorexia, nausea and vomiting, diarrhea, abdo pain, and so on. And then you've got a second line would be an NMDA receptor antagonist, such as memantine. And if you're aware that NMDA is often, again, involved in wakefulness and things, you'd wonder why would you want to have a drug that antagonizes this if you're trying to help somebody's memory and things. And it's actually because it prevents the excitotoxicity that is sort of killing the cells, essentially. But it doesn't affect your memory and learning functions because it's triggered by a certain voltage level. So the kind of lower voltages get to keep going. But just be aware of those sort of drug names because they are useful to know for exams. Again, side effects kind of similar, actually, diarrhea, dizziness, etc. So this is just a few side notes on sort of extra things you could do, such as olanzapine if they're agitated. And obviously it's not got a great survival. The prognosis is quite poor, 7 years. And then bronchopneumonia, as I'm sure you're probably aware, is often a big cause of death for these patients. So that's Alzheimer's. The rest of it, you'll be pleased to know, is mainly quick bullet points. But I thought I'd cover Alzheimer's slightly more because it's more common. So vascular dementia is about 25%. And the classic thing you need to know for exams, stepwise deterioration in cognitive function. and memory secondary to numerous small infarcts. So often these patients will have a history of things like TIAs, stroke, lots of cardiovascular risk factors, and that will all point you in a question, for example, towards this diagnosis over perhaps Alzheimer's. But that stepwise deterioration is the key bit. And you want to just modify these risk factors. What's been done has been done in some senses. If they've had a stroke, you can't reverse that, but you can try and prevent them having further vascular events. So aspirin, good BP control. And even though those other drugs we talked about are actually Alzheimer's drugs, they do sometimes get trialed for vascular dementia because, I mean, it does less harm than the sort of side effects. So dementia with Lewy bodies, we'll just touch on. So it's this alpha-synuclein Lewy body deposition in the frontal and temporal lobes, and it's that kind of neuroanatomical location that causes the sort of symptoms they get. So neuropsychiatric features is the key bit, like visual hallucinations, Parkinsonism, as we mentioned right at the start. Fluctuating mental state is a useful exam phrase to remember. And often the memory dysfunction isn't the earliest feature. It might be the hallucinations or sort of fluctuating consciousness. And again, it's not curable, but they might still try the Alzheimer's drugs. And for the Parkinsonism, you can manage kind of like how you would the kind of idiopathic Parkinson's disease with levodopa. So frontotemporal dementia, not very common at all. I've seen it and things, but it's not as common as the other ones. So it's worth having an awareness for exams that these patients would be the ones with personality changes and impaired social function over perhaps some of the other sort of features of Alzheimer's and things. They might be disinhibited. And actually often there's a clue in the stem if the patient is slightly younger than you'd kind of expect for dementia. But that's pretty much it for that. Keep that bit short. Dementia differential diagnosis. This is an important sort of bit to take away, and we are really near the end now. So pseudo dementia is this kind of phenomenon caused by severe depression, and patients who have this often retain insight and complain of reduced function in their day-to-day life. And what happens is when you assess these patients, they'll respond to things with "I don't know," and it's to do with effort. Whereas for patients with sort of your regular dementia, they are unaware of their reduced function, so they tend to just get the questions wrong, but they give it a good go. And I think this might actually be the last slide, but it's quite an important one if you can sort of have a look over this in your own time as well, because it's set out in almost the OSCE style. Is when you're investigating memory loss, it's useful to rule out things like anemia with full blood count, using these for your dehydration and AKI, LFTs, glucose, TFTs, and it's all these sort of reversible causes that you want to be thinking of. Imaging, CT or MRI, and the most common abnormality for patients with dementia, and indeed for patients sort of in older age, will be atrophy in the brain. And there's just some other investigations to consider there. And you'll be pleased to know that that's everything I wanted to cover. I hope that's been useful. Sorry, it might have gone on a little while. I hope your brains are doing okay, but the slides will get out to you, and I hope that's been of some help anyway.